Rohit Sujin to present his case, Change the Track.
Good morning, everyone. I'll be presenting in behalf of Medicine 3, Change the Track. So presenting a 54-year-old Mr. Rex, who's a farmer, presented to the emergency department with the complaints of giddiness and syncope since morning and recurrent episodes of vomiting since morning. On 26/8/2023, around 7 a.m., while he was using his restroom, he had a sudden giddiness and had a fall, followed by which he had a transient loss of consciousness, followed by which he was immediately taken to nearby GH, where he was symptomatically managed for a period of 1 day and was referred to CMC for further management. When she had initially come, he had complaints of coughing while eating. He also had complaints of spinning of the room around the head, complaints of repeated episodes of vomiting immediately after the intake of food. He had complaints of reduced sensation over the left side of the face and had complaints of difficulty in swallowing of food. He also had difficulty in walking and imbalance while walking and also swaying towards the left side. No history of difficulty in moving the upper limb and lower limb. No history of loss of smell. No history of diplopia on sudden movement of the eyes. No history of or difficulty in opening and chewing the food. No history of deviation of angle of mouth. No history of hearing or continuous sounds. No history of inability to feel the ghost. No history of feeling a bite of the mosquito. No history of difficulty in feeling hot and cold water. No history of bowel or bladder involved. No history of autonomic involvement. Past history wise, the patient is a known case of Wolff-Parkinson-White syndrome, diagnosed in 2017, who was lost to follow up or not under any medications. He is a known case of hypertension from 2017 on clinidipine 5 mg BD, which is also he was not lost to follow up. Not a known diabetic and reformed alcoholic for the past 1 year. Examination when he had initially presented, the pulse rate was 86 beats per minute, regular, respiratory rate was 18 beats per minute, he was afebrile, BP was 140/90, GCS was 15/15. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. The JVP was not elevated. CVS was the first and second heart sounds are heard, and the apex is when the fifth intercostal medial to the mid-clavicular line. The abdomen was soft, no organomegaly was present, the respiratory system was within normal limits. Examination of the central nervous system. When he had initially presented, the higher mental functions were normal. Examination of the cranial electrical reactive, the pupils were 3 millimeter in diameter and equal in size and reactive. Extraocular movements were normal. There is no restriction in echo movements. Examination of the fifth nerve, reduced pinprick sensation was felt in the left side of the face. There was no deviation of angle of mouth, no difficulty in closing the eyes. The examination of the eighth nerve was normal. The examination of the ninth and the 10th nerve, gag was obtained. The uvula was deviated towards the left side. The 11th and the 12th cranial nerve was normal, and there was no features of Horner syndrome. Examination of the motor system. The examination of the motor system were within normal limits. The tone did not have any features of hypotonia. There was no limitation in the power, and the deep tendon reflexes were normal. The plantars were flexors. Examination of the sensory system. There was reduced pain sensation in the right upper limb and lower limb compared to the left side. In cerebellum, pass pointing was noted mildly in the left side. Gaze evoked nystagmus was present. No dysdiakinesia or rhombic sign was positive. Examining no meningeal signs, spinal skull were within normal limbs. Summarizing, a 54-year-old male with a history of acute onset of vertigo with swallowing difficulty, with the involvement of left-sided 5th, 9th, and 10th cranial nerves, the involvement of the left-sided cerebellar involvement with right-sided reduced pain sensation. So, owing to the acute event, the diagnosis of acute cerebellar accident, clinical localization of the left lateral medulla was made. On initial evaluation, his routine parameters were normal limits. A chest X-ray was also normal. So this was the initially when he had come. ECG had shown features of Wolff-Parkinson-White. Here you could see the delta waves of Wolff-Parkinson-White syndrome, and it's predominantly predominantly right. The initial pathway was we did not have what pathway it was. However, it was diagnosed in 2017. He was not on any medications for the same. MRI done at that time had confirmed the findings. It had found features of left lateral medullary involvement with the indicator left pica impact. However, on evening rounds on 39/2023, the patient was noted to be in minimal discomfort. On examination during that time, he was found to have a pulse rate of 160 beats per minute, which was regular, BP of 130/90, respiratory rate of 18. He was afebrile, conscious oriented. Systemic examination during the time was within normal limits. During that time, we had taken an ECG. ECG had shown features of this. Can anyone like to have a comment on what this could be? The patient was hemodynamically stable and this was the ECG done at that time. So owing to time limits, we'll just carry on. So basically, we could all know this, the white complex tachycardia is looking like a white complex tachycardia. So basically going into the algorithm, being a white complex tachycardia, it could be a regular or irregular tachycardia. Being a regular, it was a regular tachycardia. So these are the three possibilities we could get. A monomorphic ventricular tachycardia, any supraventricular tachycardia with aberrancy, any antidomic atrioventricular reentrant tachycardia, most commonly associated with WPW syndrome. However, precise diagnosis has to be made in case of treating these patients because a wrong diagnosis could cause an imminent cardiac arrest in these patients. So based on the routine ACLS protocol, we went ahead. So patient had a beat of 150 beats per minute. The airways was patterned. He was not hypoxemic. Cardiac monitor was in place. We had IV access in line. 12-lead ECG was in place. He did not have any features of hypotension, altered sensorium, signs of shock, ischemic discomfort, and acute heart failure. So coming into the algorithm, when it says no, the white complex tachycardia, adenosine would be the first choice in this patients. However, we know that the patient is a known case of WPW syndrome and it needs to be taken into consideration. And I like to explain why it needs to be taken into consideration. And is adenosine is good enough for terminating the white complex tachycardia that had occurred in this patient? So I like to speak on antidomic atrioventricular tachycardia with Wolff-Parkinson-White syndrome, which is a rare beast. 80% of the Wolff-Parkinson-White syndrome people who have developed arrhythmia develop AVRT, atrioventricular reentrant tachycardia. Among the AVRT, there are two types, which is mainly orthodomic type and antidomic type. Orthodomic type occurs in 90 to 95% of the people, and antidomic type occurs in 5% of the people. Rest of the 10 to 20, 30% are predominantly associated with an atrial fibrillation with a pre-excitation, which is of imminent importance because the treatment management depends on it. So I like to explain the mechanism of what is a orthodromic type and what is an antidromic type. Basically, in case of Wolff-Parkinson syndrome, as we all know, there is a aberrant pathway known as a bundle of Kent. So in case of orthodromic type, basically the re-entry, there are two pathways: the entry pathway, the re-entry pathway. The entry pathway is from the atrium to the ventricle, and the re-entrant pathway is from the ventricle to the atrium. In case of orthodromic, the entry occurs via the AV node and the re-entry occurs via the accessory pathway. Accessory pathway, as all we know, has increased refractiveness so that the conduction is slow via the accessory. Conduction is rather, every impulses are conducted via the accessory pathway. However, they are very slow. However, in case of an antidromic type, the entry is via the accessory, the re-entry is via the nodal pathway. It indicates the AV node is essential in our body because it prevents it does not allow all impulses from the atria to enter into the ventricle. However, in case of the antidomic pathway, all impulses produced in the atria are going into the ventricle, thereby re-enters into the atrium via the re-entry pathway. So this is a orthodomic type of AVRT which occurs in 90 to 95% of the people with a WPW syndrome. Usually, it is a narrow complex tachycardia, which excludes from our case. It usually 200 to 300 beats per minute. It usually has a retrograde P waves and can be treated by AV nodal blocking agents like adenosine. However, coming to our patient. So our patient had a white complex tachycardia. It could be one of the possibilities, antidromic AVRT. So other possibility I would like to mention is an atrial fibrillation with a pre-excitation can also present with a white complex tachycardia rather than the normal atrial fibrillation we see. So basically, in case of antidomic AVRT, which occurs in about 5% of the cases, it usually comes at a base of 200 to 300 beats per minute, and it's a white complex tachycardia. However, it's very difficult to distinguish antidomic AVRT with ventricular tachycardia. And in case of any doubts, we need to treat it as a ventricular tachycardia. And the second would be an atrial fibrillation in WPW syndrome, atrial fibrillation with a pre-excitation. So it occurs in 20% of the patients with WPW syndrome. It occurs as a irregular. It usually occurs as a white complex tachycardia with irregular beats. However, you can only see subtle beat variations in the QRS complex. And the drug of choice here is procainamide, and the other which can be used is cardioversion. So why I want to focus on this slide is In case of antidromic AVRT in atrial fibrillation, both which are associated with wide complex tachycardia, using of AV nodal inhibitors prevents the entry of impulses from the AV node into the AV node, blocks the AV node, preventing the entry of impulse from atria to the ventricle, thereby allowing all impulses to go from atria to directly into the ventricle. So in case of an atrial fibrillation which beats at over 500 beats per minute, all impulses, if it goes into the ventricle, thereby produce and whereby changes the ventricular tachycardia into supraventricular tachycardia into an ventricular fibrillation, thereby lead to an imminent cardiac arrest. So basically, it is essential that we need to make sure that it's not a antidromic AVRT or atrial fibrillation with a pre-excitation before giving any before blocking the AV nodal pathway. So in case of so it's essential according the most common things associated with the wide complex tachycardia in WW syndrome, antidromic AVRT and a pre-excited atrial fibrillation, both of which the common drugs adenosine, verapamil, diltiazem, which we commonly use for supraventricular tachycardia, are contraindicated. Not contraindicated, but it should be used with very caution that the patient can go into an imminent. If in not case of in uncertainty, we can the first line of drug would be procainamide, which is not available here. So the second, which we can go ahead with an signarized cardioversion. So in our patient, after obtaining consent and sedation, we had cardioverted initially, followed by which he had obtained his sinus rhythm. Followed by within seconds, he had reverted to again antidromic AVRT. So after obtaining cardiology consent, we had went ahead with an adenosine and metoprolol were tried. However, eventually we did not obtain sinus rhythm. So we had to go with a second cardioversion in order to obtain a sinus rhythm. So this was the sinus rhythm we had achieved after the cardioversion. So our patient was stabilized and was referred to cardiology for catheter ablation of the axillary pathway.
Thank you. So you only suggested it's usually contraindicated using AV block. Then you have used the same thing in your patient. So what is your message then?
Sir, after ruling out, sir, after cardio persistent, we ruled out a probable.
Because you have very fraction of time for you to act, no? Because it's very difficult for you to differentiate all this at the bedside when you have a wide complex tachycardia. So how did you arrive at a conclusion that were you able to differentiate? Because for any clinical person, it's very difficult to do at the bedside at that moment. So how did you differentiate all this and you took a call?
So the guidelines say that it's very difficult to when it's very difficult to differentiate, you need to treat it as an unstable ventricular tachycardia. Even though it's just, our patient was very stable. So though it's stable, we need to treat an unstable tachycardia. So we entered with a direct DC cardioversion. Same. Sir. After ruling out the secondary causes.
You had done a previous echo, we know, because this
we had done a previous
patient presented with a stroke. Yes, I understand. Cardioembolic going to be very minimal with the posterior circulation stroke, but there's still a 5 to 10% chance it could be cardioembolic.
In the meantime, between the 2 days, he had admitted on 28th. We got this before that we had a echo which was saying normal, sir.
Normal.
We ruled out and he was already started on heparin for the prophylaxis.
Prophylaxis for what, heparin?
Sir, he was predominantly bedridden, so we had started heparin for DVT prophylaxis. So coagulation.
Use, heparin for posterior circulation stroke.
Not for posterior circulation.
For he had an acute posterior circulation stroke. So, but you used heparin for a venous thromboprophylaxis.
Yeah, since he's predominantly bedridden for thrombosis.
The forum is open for questions. My last question is there any safest alternative for you? Like if it's not, you said the first attempt, he's not reverted with your cardioversion. So if they couldn't able to differentiate, still there is a confusion that we can't use nodal blockage. So what could be the safest alternative?
We had thought of amiodarone, sir, but cardiology even felt that amiodarone could also have been the same as like the contraindication, the drugs which you used to in caution. Amendron also was mentioned.
Okay, thank you. I now request the second person, Dr. Tefila, to present to die or to die.